So my project is on work accommodation among low to middle income pregnant women. This is an expansion of a project that was done by a previous ERC trainee with the goal of expanding the patient demographic. So just a little bit of background. There are more than 1.5 million pregnant workers in the United States, and women tend to be working longer during pregnancy. About 3/4 of pregnant women intend to go back to work after maternity leave. And there was a study in 2008 showing that about 80% of pregnant women work through the third trimester. So there are many different pregnancy risk factors associated with work. For example, night shift workers in particular tend to be at higher risk. Women who do physically strenuous work and prolonged standing, both of these things have been associated with poor birth outcomes. Other things to consider are extremes of temperature and chemical exposures. Just to highlight a couple of examples, in terms of chemical exposures, there have been studies showing that perchlorate, which is a chemical that women who work in dry cleaners are exposed to, can cause higher rates of spontaneous abortion and low birth weight. Just so we can review pregnancy and the American Disabilities Act, it's important to recognize pregnancy alone does not mean disability. However, if there are temporary disabilities that arise from being pregnant, things like physical symptoms like back pain, sciatica, physiological impairments, and any type of impact to the organ systems, including those that place the fetus at risk, those must be treated as any other temporary disability. This does not mean that you can discriminate if you think a pregnant worker has a disability. So for example, if you have someone who works in a munitions factory, even if they're visibly pregnant, you cannot make the determination yourself to remove them. You can counsel them on their risk factors and have them request to be removed, because failure to do that would be treating someone as regarded as having a disability. So with that, I'll launch into the study methods. Women who are eligible for a study were pregnant, at least 18, speaking English or Spanish, because that was a limitation of our survey. We had English surveys and Spanish surveys. The pregnancy had to be a singleton pregnancy, and women had to be either in their second trimester or later. And for our recruitment location, we recruited at the ambulatory care clinic in the Klingenstein Pavilion at Sinai. We recruited for about 4.5 months. We would have liked to recruit more, but COVID truncated our recruitment. So the survey instrument is adapted from a validated survey that looks at the different aspects of work, including number of hours worked, risk factors associated with work, etc. We collected demographic data on pregnancy history, their current job. The questionnaire also looked at current job characteristics, and we also looked at accommodation requests. So we asked women if they thought they needed an adjustment to their work. We asked them if the request was granted. If so, what types of accommodations were made. And in addition, we did a post-delivery chart review. I tried to wait until about 6 weeks postpartum to capture the postpartum visit. So we looked at pregnancy complications, like having a pregnancy-associated hypertension disorder, looking at birth outcomes like the prevalence of low birth weight, preterm birth, and whether the infant was admitted to the NICU. So for our recruitment, we screened 373 women. 93 were excluded because they weren't working. 44 women were excluded for other reasons. Either it was multiple pregnancy. You also had 67 women who were just not interested. We had 169 women who consented to participate in the survey and chart review. We ended up excluding an additional 4 from analysis due to them being first trimester when we calculated the dates. And then we had 1 participant who later reported after starting the survey that they were not working outside of the home. So that left us with 164 participants who are eligible for inclusion in our analysis. We coded the participants' primary job using the 2010 standard occupational classification system. We ran it through an automatic coder. We then did descriptive analyses to look at the demographic data and pregnancy history. And I also looked at the prevalence of work modification requests made and granted. For the chart review data analysis, we looked at the prevalence of preterm birth as defined, low birth weight, and whether they had a pregnancy-related hypertension disorder. So that includes women who had preeclampsia, eclampsia, but they could also just be diagnosed with gestational hypertension, chronic hypertension, or proteinuria. We also looked at gestational diabetes, whether they had a C-section, and as I mentioned earlier, whether the infant was admitted to the NICU. So these are the top 5 occupational categories of the women in our survey. As we can see, some of the more common occupations were sales and related, like cashiers and customer service reps, and those working in healthcare support. So your home attendants, your medical assistants, etc. And this is a summary of our demographic data. Only over 20%, only about 25% of women had a bachelor's degree. So, and 40% of women had a high school education or less. This population was predominantly lower income. We had a predominantly Black and Latina population of women. And this is for the data, this was for the women for whom data were available. We also looked at some of the measures of economic, self-reported economic strain, because a lot of times their studies have shown that sometimes women may be hesitant to request a work accommodation if they feel that they're going to be at risk of losing their job, and especially among those who have much less economic flexibility. So as we can see here, you have almost half of the population admit to having difficulty living on their current income. So you can imagine how that might impact a pregnant woman's decision to work through her pregnancy, whether she is at increased risk or not. So in terms of work accommodations, surprisingly, about half of the participants in the study felt like they didn't need any change in their work tasks. Particularly, you can imagine, for example, if somebody's working as a cashier and they have access to a chair, and they could otherwise do their work if their schedule is set up so that they can use the bathroom as needed, etc. So in some ways, that's not surprising. 65 women requested an accommodation, and about 2/3 of those requests were granted. The most common accommodations were reduction in hours and modifications to tasks that involve weight. So less lifting, carrying, pushing, etc. For pregnancy outcomes, over a quarter of the women had reported a pregnancy-related hypertensive disorder, and this is consistent with, this is actually consistent with the data for East Harlem as a whole. We see also women who have gestational diabetes, postpartum hemorrhage. The preterm birth rate is just a little over 5%, and almost 30% of the women had a C-section, and 1 in 5 had a NICU admission. So these are just the preliminary data because everything was delayed by COVID. So the next steps of analysis for me are to take a deeper dive into looking at occupational category versus pregnancy and birth outcomes. I'm going to look at differences in job accommodation and whether there's an association between getting an accommodation and the different birth outcomes. I'm also going to look at the data on whether work accommodations are even discussed during provider visits. And I also would like to do further analyses on the measures of financial strain and whether that impacted the likelihood of requesting a job accommodation. So I would like to thank Ariana Shanzer, who is my fantastic research assistant, who is now a first-year medical student at NYU, my alma mater. So I guess I've come full circle. And I'd also like to thank Dr. Afzal and Dr. Meyer for their support with this project and the ERC pilot project program. So with that, I'll take questions.
Candace, this is Steve Markowitz. Can you hear me?
Yes, I can.
Yeah, hi. Nice presentation. I don't know if you follow the new MTA rule for their pregnant employees, but if you do, what do you think of it?
No, I have not followed the new MTA rule. I'm still coming out from understudying for boards, so I'm trying to catch up on everything new.
Okay.
What's the new rule?
Oh, certain job classifications, they're going to give them light duty job, but only certain job classifications. So I'm not sure the distinctions they make make a whole lot of sense, but it's worth looking at because it's very timely.
Mm-hmm. Okay, great. Thank you.
Sure.
Hi, Candace.
Hi.
I had 2 questions. This is really fascinating, and I have about a zillion questions, but 2 that popped into my mind were if you had the distribution of those in the 2nd trimester versus the 3rd trimester, and if there was any stratification based on that at all, given most women tend to feel pretty good in the 2nd trimester, and then it's really the 3rd trimester where everything starts to hurt. And I was wondering if there'd be any difference there. And then also if you had any information on whether the participants were working full-time or part-time, and if there was any stratification based on that.
So those are great questions. In terms of the question about the trimester, so I ran the analysis on the prelim set of data that I submitted to the ACMED conference, and last I remembered it was evenly split between 2nd and 3rd trimesters, but I didn't run those analyses with the most updated numbers. So, and then, sorry, what was your other question again?
Oh, if you captured full-time or part-time work status.
So we actually looked at the number of hours worked per week. So I plan to incorporate that in my the next round of analyses, because like I was saying, I just started looking at the data. So stay tuned in February.
Sounds great. Great work. Thank you.
Okay, thank you, Candace. I think Mary Grace also had the same question. She said, did you assess what week subjects delivered at? So I think, Candace, you want to consider that for your analysis.
So, sorry, actually, in response to that, as I mentioned earlier, only about just a little over 5% were born before 37 weeks. So actually, most of the women in the study, the overwhelming majority, delivered at term, whether it was C-section or vaginal.
It's actually
thank you.
Just to jump in, it's an interesting point, because we deliberately sort of looking at the low income, catchment area for Mount Sinai, East Harlem, and northern parts of Manhattan, and the preterm labor and preterm delivery rate is actually a fair chunk. Well, it's probably about half of what we would normally see, which, we're hoping is good. It may be that an employed group of people, even if they're employed in not ideal jobs, may still be doing better than the overall population, particularly the non-employed.